pleasure for me to introduce Justin Ryan, coming to us from Phoenix Children's Hospital. Justin educationally has a background, BS in digital art and animation, and then went on to have a master's and PhD in biomedical engineering, which I think is a really interesting skill set. He was one of the, he runs the 3D printing lab at Phoenix Children's and was one of the first folks there, and that's 4 years experience there, and then another 4 years before that in the 3D printing area making models at Arizona State University. And he's somebody I know and respect for the work in cardiovascular modeling, and he tells me that he's done more than 300 hearts, which to me sounds like a good amount of experience in heart modeling. So I'll welcome Justin.
So my name is Justin Ryan. I've been doing 3D printing for a few years at Phoenix Children's Hospital. We've been very proficient in creating a very decent workflow on creating heart models as well as other anatomy. But today I'm going to talk a bit about the background of our lab and what we've since moved into. And it's this whole idea of building evidence in medicine, specifically via clinical trial. So I don't have any disclosures to make, so I'll jump right into it. We're going to give a brief overview of our heart topic in this case, followed by a retrospective analysis of the first 150 hearts we produced a couple of years ago at Phoenix Children's, leading into this multi-center clinical trial that's going to be prospective and hopefully be one of the first stepping stones to creating the evidence we really need to get reimbursement. So congenital heart disease is our focus at the lab. It is very important to treat 1% of pediatric patients are born with a defect, leading cause of death, infants, neonatal, postneonatal, so extraordinarily important. And unfortunately, the planning for this isn't patient-specific, not to the point that we expect it to be. We look at CTs and MRIs, and by and large, especially the smaller institutions, they're still looking at two-dimensional images, flat images on a two-dimensional screen. Even if they proceed into volumetric rendering, they're looking at a 3D model on a two-dimensional screen without any scaling information. And 3D printing really provides a mechanism for changing all of that. So here we have the normal human heart, and it's what we've all seen in textbook drawings. But when we start to add defects to it, we start to complicate. We have septal defects, hypoplastic ventricles, truncus arteriosus, and they just start to compound one after another. And these are idealized drawings. In the actual scenario, those defects compound on one another and create even more complex pathologies that surgeons, interventionalists treat. And those were drawings. So these hearts, every single heart at the hospital is unique. So we don't typically see a scenario like this where we print a heart and then we can treat it with another patient. But we're addressing that, especially the people in this room are addressing this concept, 3D printing hearts. And in fact, I did a Google search the other day to see what type of news we have on 3D printing of hearts. So I did a pretty stringent filter on Google, 3D printed hearts. The last year, just looked at the first 2 pages alone on news articles, and a flooding of articles have come out. So we're all doing this, but we're creating qualitative medicine, anecdotes that don't translate to the information that we all need as a collaborative community. So the question now is, where do we go from here? And maybe a better way to phrase that is, what should our goal be? And of course, the whole concept here is we're trying to build evidence. We're trying to build evidence so that we can support this technology. Following my talk yesterday and the person directly after me and following directly after that, the question that always came up was, how do you pay for this technology? And right now, we get grants, we get donations, endowments, and we're a smaller institution ourselves, so we don't get a lot of those big grants and a lot of those big endowments. So we're really bootstrapping a lot of what we do. But once we create the viable model, we can achieve reimbursement. And clinical trials and evidence along the way are going to support that. So once we pay for a model, we can treat more patients. But then once we get reimbursement, we create a whole new medical scenario where we can have 3D print labs throughout hospitals that are large enough to support them. Or we can create isolated print labs that print for hospitals. So it's all about this concept of reimbursement, reimbursement, reimbursement. This is what always comes up at all of these talks that we go see. So to address this, we did a retrospective analysis at Phoenix Children's. The study was to see how have we affected care at Phoenix Children's at this point in the first 2.5 years of our program. So we looked back, and at that point we printed 150 hearts. We realized that only a section of those were for surgical planning, 88 models. We also did some for interventional and hybrid procedures, but we narrowed down our analysis to 88 patients. And we compared surgical time frames, specifically cardiopulmonary bypass time. And what we found was nothing. It was extremely meaningless. We saved maybe 2 minutes overall, achieved no decent p-values, but when we look at the overall data, suddenly we start to see why that is. We have very simple procedures that we're comparing one versus a very complex two-ventricle procedure. A surgical closure of a PDA might take 30 minutes, but a double outlet right ventricle scenario might take 6-8 hours or more. So we needed to refine what we were looking at. So we looked at a specific disease subset, looked at the 3D printed models for these cases, and then looked at the same time frame, similar cases. And what we also saw here, still not a whole lot. We have really bad p-values from an engineering scientific standpoint, but we do start to see a little bit of a reduction in time, and we start to see maybe some possibilities of meaningful information. So once again, we went further down and detailed, and we looked at specific disease subsets, double outlet right ventricle and truncus arteriosus in this case. And we still don't achieve those nice p-values of 0.05, even 0.1 in this case, but we start to tell a narrative. With the double outlet right ventricle, we're having a reduction in surgical time more than 120 minutes in some of these cases. So we see a strong potential, but now we need to realize that potential. We need to have the actual powering to have those nice p-values to really convince the American Medical Association, to convince the insurance companies to proceed with this technology. And it's not just about the numbers, it's also about the perception of this technology. This was a quote from our surgeon relating a RVPA conduit that was being placed. And prior to looking at the model, he thought he had it all planned out. But once he saw the 3D print, he saw a coronary right in the path where he was placing that conduit. And that could have been catastrophic for that patient. So not only do we have the soft numbers, we have this anecdotal evidence, but once again, the prospective clinical trial. And that's what I'm here about. At DC Children's National, Children's Hospital Philadelphia, and Phoenix Children's, we're leading a multi-center clinical trial looking at the effect of 3D printed models on a very specific disease subset and the two-ventricle repair, in this case, double outlet right ventricle. Beyond here, we have 9 to 12 sites who have given their verbal approval and are somewhere along the way in the IRB approval process. So what we will be looking at here is the evidence to create reimbursement. And as an overview of the trial, we're trying to structure this as strongly as we can. We're going to single blind the trial. It's going to be randomized controlled. We've powered it to be 388 patients split into 2 arms, and that powering came from looking at just if we can achieve a 15-minute reduction in surgical time, then we will achieve a strong p-value, one worth presentation. At this point, we're estimating about a 2-year completion for the trial, but we have built into the trial and our powering to do a 50% interim analysis as well as 75%. So there is a potential to end early, and we are actively recruiting centers along the way, so this time might get trimmed down. The whole concept here is, of course, effectiveness. Can we reduce morbidity? Can we reduce mortality? That is the key here to show that 3D printing is a tool to be used in surgical planning. Our primary endpoint in this case is going to be cardiopulmonary bypass time, but we are looking at 30 other metrics that are already reported by the institutions in their STS database. So we already have the information built into their workflow process. It's just about querying that information for our process. To break down the trial a little bit more, we start out with 388 patients based off a randomized scheme. We are breaking them up to 2 groups. All patients in the trial will send preliminary information and images to Phoenix Children's Hospital. We'll be doing the reconstruction, and we've secured 2 vendors at this point to do the 3D printing, both in a rigid and flexible media, so that everyone participating will have both technologies available, be agnostic towards the technology. The surgical planning will proceed as the institution permits. The surgery will happen, and they will report both immediate data as well as 30-day post-op data to the data coordination center, in this case, Children's Hospital Philadelphia. So following this program, if we can see a very minute reduction in time, we will have achieved our goal. And even 15-minute reduction in time based off literature and internal review We will have helped the patients in their quality of life. The reduction of stroke is drastically reduced by that 15-minute reduction. We have reduced the potential for infection. We will have even overcome the cost associated with those models in that 15-minute reduction within the OR. So all that is critical and we hope to see for this trial. So the next part is, what are the next steps? Right now, the 2 of the 3 primary sites have IRB approval. A third is aiming to achieve that within the next 2 weeks. We also need to post on clinicaltrials.gov, and that's probably going to happen in about a month's time. And then the recruitment can begin immediately after that. Following recruitment, it's going to be a rolling process, so additional institutions can join along the way. But really the next step here is, once again, reimbursement. That's what we're all here for. Now, of course, there's a caveat and the asterisk there. This itself may not be that mechanism, and it likely won't be, but it will be a major stepping stone to creating the evidence that we need to achieve reimbursement. And while there isn't time right now for questions, I certainly welcome you to reach out to me directly at Phoenix Children's if you want to review the protocol, if you perceive your surgeons at your site can participate in this clinical trial. Thank you.